Les les pedimos un minuto más para que las personas que están todavía en proceso de ingresar.
Ok,
De acuerdo. Muy bien. Bienvenidos y bienvenidas a este seminario regional virtual sobre DoxyPEP y su potencial impacto en la reducción de la sífilis en las Américas. Este webinario o seminario está organizado conjuntamente por la Organización Panamericana de la Salud y el Grupo de Cooperación Técnica Horizontal. Buscamos como objetivo general promover un diálogo técnico regional sobre DoxyPEP y su potencial contribución a la reducción de la sífilis en las Américas mediante el intercambio de evidencia, experiencias y perspectivas programáticas que pueden orientar líneas de acción en la región. Este es nuestro objetivo y para eso nos hemos reunido y hemos abierto este espacio en el cual pues agradecemos su presencia. Vamos a ceder el micrófono al doctor Carlos Chávez, quien es secretario ejecutivo del Grupo Cooperación Técnica Horizontal y jefe de la sección de ITS y VIH y SIDA del Ministerio de Salud de Panamá. El doctor Chávez lidera importantes iniciativas nacionales en materia de prevención y atención y más adelante nos compartirá la experiencia y visión de Panamá frente a esta nueva estrategia. Por ahora le voy a ceder el micrófono al doctor Chávez para que nos dé la bienvenida a nombre del GCTH.
Hola, muy buenos días a todos y bueno, buenas tardes para quienes nos acompañan desde distintas regiones de distintos países de la región. En nombre del Grupo Cooperación Técnica Horizontal, les doy la más cordial bienvenida a este seminario regional virtual dedicado específicamente a analizar ese impacto potencial que podrá tener la profilaxis por exposición con doxiciclina que conocemos ya todo como DoxyPEP, como una herramienta que va a representar una innovación para contribuir a la reducción de la sífilis y otras infecciones de transmisión sexual bacterianas en las Américas. Quiero agradecer profundamente también a los representantes de los ministerios de salud, a los organismos de cooperación internacional, a la academia, a la sociedad civil, redes comunitarias, investigadores y profesionales de la salud que nos acompañan. Y bueno, este acompañamiento que están haciendo el día de hoy refleja ese compromiso que tenemos como región para fortalecer la respuesta basada en evidencia, derechos humanos, equidad y salud pública. Creo que es muy bien conocido por todos nosotros que la sífilis continúa siendo un reto y un desafío creciente en nuestros países y que el aumento sostenido de los casos tanto de sífilis adquirida como los de congénita nos exigen explorar nuevas estrategias para realizar prevención, tratamiento oportuno, vigilancia epidemiológica y promoción de la salud. Y bueno, en este contexto creo que la DoxyPEP da una respuesta muy importante y es de muy interés mundial debido a que a todos estos resultados que hemos obtenido en diversos estudios y algunas experiencias programáticas en diferentes puntos del mundo, ¿no? Sin embargo, también obviamente esta estrategia va a plantear algunos desafíos relacionados con su implementación, con la aceptabilidad, con la equidad en el acceso, también en el uso racional de antimicrobianos y bueno, de la sostenibilidad que podamos tener desde los diferentes países en los sistemas de salud. Y bueno, es precisamente por lo cual este webinario da respuesta fundamental a todas algunas de estas interrogantes y también crea un espacio de diálogo que podrá entonces ampliar la respuesta a estas interrogantes que podamos presentar en el camino de la implementación. Entonces esperamos que este seminario sirva no solamente para intercambiar experiencias, sino también para identificar oportunidades y reflexionar colectivamente cómo debemos fortalecer nuestra respuesta regional hacia dar mayor cobertura a la sífilis y a otras ITS y otras infecciones de transmisión sexual. Agradezco especialmente a la Organización Panamericana de la Salud, también a la Organización Mundial de la Salud, a todos los expertos internacionales que nos acompañan el día de hoy, así como a cada uno de los panelistas de diferentes países que van a compartir esos conocimientos y experiencias el día de hoy. Bueno, espero que esta jornada sea muy productiva para todos y que sirva de un aprendizaje e intercambio regional y que potencie esa respuesta que debamos tener en la región hacia la sífilis y a otras infecciones de transmisión sexual. Así que bienvenidos a todos y bueno, espero que esta sesión sea muy productiva. Saludos.
Muchísimas gracias, doctor Chávez, por esa calurosa bienvenida. Y bueno, a nuestros participantes deseamos solicitarles que en el transcurso de todo este seminario puedan colocar sus preguntas en la casilla de Q&A, perdón, y también que si desean hacer comentarios, tienen el chat disponible. También pueden acceder a interpretación simultánea en los idiomas de español, inglés y portugués. Ahora sí, vamos a dar inicio a este seminario con la doctora Mónica Alonso. La doctora Mónica Alonso es la jefa de la unidad de VIH, hepatitis, tuberculosis e ITS de la Organización Panamericana de la Salud. La doctora Alonso cuenta con una amplia trayectoria apoyando a los países en la región en el fortalecimiento de las respuestas frente al VIH y las ITS. Nos presentará un panorama de la situación de la sífilis en las Américas y el propósito de este diálogo técnico sobre DoxyPEP. Doctora Mónica, adelante.
Gracias, Ivonne, y muchísimas gracias al Grupo de Cooperación Técnica Horizontal por convocar este importantísimo diálogo regional. También quiero agradecer y dar la bienvenida a los panelistas y a los participantes. Por un lado, el doctor Remco Peters de la OMS, el doctor Oliver Bacon de la San Francisco City Clinic, la doctora Abigail Fessler de la Universidad de Washington, a la doctora Pamela Gaspar del Ministerio de Salud de Brasil, el doctor Carlos Chávez, que habló anteriormente y nos va a volver a hablar de las experiencias en Panamá, que él es además de ser el secretario general del GCTH, es jefe de programa en el Ministerio de Salud de Panamá, al señor Fernando Díaz Pendones de COIN, República Dominicana, y la doctora Annie Lutkenmayer de la Universidad de California en San Francisco. Además, saludar a representantes de los ministerios de salud, organizaciones comunitarias, academia y socios de cooperación en la región. Hoy vamos a hablar de DoxyPEP y la DoxyPEP es para una intervención para la respuesta a las ITS, la sífilis, la clamidia, la gonorrea, pero principalmente quiero destacar, tal como refleja el título de la sesión de hoy, el tema de la sífilis y la necesidad de herramientas adicionales para dar respuesta a la sífilis, porque representa hoy uno de los desafíos más importantes para salud pública en las Américas. Según nuestras estimaciones regionales más recientes, en 2024 ocurrieron 4,2 millones de nuevos casos de sífilis, aproximadamente medio millón más que en 2022, un aumento del 15%. Y el 90% de estos casos se concentra en América Latina y el Caribe. Y evidentemente, cuando hablamos de sífilis, la situación nos preocupa muchísimo también por el tema de la sífilis congénita. La tasa estimada de sífilis congénita alcanzó los 5 casos por 1.000 nacidos vivos en 2024, es decir, 10 veces más de la meta de eliminación. Nosotros, como OPS, apoyamos a los países, tenemos la iniciativa de eliminación de enfermedades transmisibles, tenemos la iniciativa de ETMI Plus y estamos promoviendo herramientas y nuevas estrategias de respuesta. Y estos datos nos recuerdan que la respuesta a la sífilis requiere una combinación de intervenciones. En este contexto, la DoxyPEP surge como una innovación extremadamente relevante. Como toda innovación, su implementación requiere una planificación cuidadosa. Debemos considerar aspectos relacionados con la vigilancia de la resistencia antimicrobiana, la integración en los servicios existentes y la aceptabilidad para las comunidades, así como la equidad en el acceso. La experiencia de las Américas es particularmente valiosa para esta discusión. Ciudades como San Francisco y Seattle han generado evidencia programática muy relevante que vamos a escuchar hoy, mientras que países de nuestra región, de América Latina y el Caribe, ya están explorando diferentes mecanismos para evaluar su incorporación dentro de las respuestas nacionales. El objetivo de este webinario es precisamente facilitar este intercambio técnico basado en evidencia. No se trata únicamente de discutir una nueva herramienta, sino de analizar cómo podemos fortalecer las estrategias para reducir la sífilis y avanzar hacia la eliminación de la sífilis congénita, especialmente de manera más efectiva en las poblaciones más afectadas. Entonces, esperamos que este diálogo contribuya a orientar las futuras decisiones en los países y fortalecer también la cooperación regional para que entre todos podamos realmente eliminar la sífilis y la sífilis congénita en las Américas. Muchas gracias.
Muchísimas gracias, doctora Mónica. Tiene usted toda la razón y compartimos absolutamente sus palabras. Y creo que para dar continuidad a este análisis que usted nos ha hecho, ¿verdad? Del panorama de la situación de sífilis en las Américas, el doctor Remco Peters va a hablarnos de la doxiciclina PEP en el contexto global, evidencias emergentes y consideraciones normativas. El doctor Remco Peters es oficial médico para la atención y tratamiento de las ITS en la Organización Mundial de la Salud. Ha contribuido de manera significativa al desarrollo de las orientaciones normativas globales en materia de ITS y compartirá estas evidencias emergentes y las consideraciones normativas sobre DoxyPEP a nivel mundial. Dr. Peters, welcome. Please go ahead.
Thank you very much, and good morning, everyone. I just want to check, do I try again to share my own slides, or is there someone who can project them?
Ivonne, ¿podrías proyectar? Porque Remco tenía dificultades. ¿Ha recibido las diapositivas del doctor Peters?
No, doctora, no las he recibido aún.
I will do.
Okay, Hortensia is going to share.
Thank you, Hortensia. Amazing. Thank you. So, for the next 10 minutes or so, I'm going to take you through the guideline process that we conducted at WHO to generate a recommendation on doxycycline PEP. And what I'm going to do is I'm going to talk about the evidence generation process, the considerations that the guideline group had, and the recommendation that led to. There's a lot of discussion around implementation as well and implementation options, but I know some of the other speakers will talk about that. So I'm not going to talk on implementation considerations, but there's a lot of space in that space. Can I have the next slide, please? So I think the previous speakers have really highlighted as well that we are really concerned about the rising rates of STIs in general, and I think in particular the rising rates of syphilis. And this is happening in many settings around the world, but certainly in your region there's really concerning increases in syphilis. So we really need to think around interventions that can control the rising epidemic. And prevention is really a cornerstone in public health. And we speak a lot about testing and treatment for syphilis, but prevention is not always at the forefront of the discussion. And one of the reasons is that it's simply there's few preventive options. We don't have an effective vaccine, and for syphilis it will take quite a long time, I think, before we have one. And obviously there's the challenges around condom use. So preventive options for syphilis are really, really limited. And at the same time, we know that use of medicines is really a well-established prevention strategy for infectious diseases. So this got to the development and the thinking around we use doxycycline as post-exposure prophylaxis for bacterial STIs. And as you know, a lot of the studies were done in recent years to try and address this question. Next slide, please. So when we look at this question from the WHO perspective, when we develop a guideline, it really is quite a rigorous process. So there's a whole handbook for guideline development that sets criteria, and it sets the process that needs to be followed to get to a recommendation. So this is not just expert opinion. It's really an expert panel, an independent expert panel called the Guideline Development Group that reviews the available evidence and comes up with a recommendation based on standard methodology. And it's important to say that this guideline group always has an appropriate regional and technical representation. So we want the guidelines to be representative or at least be useful for as much globally as possible. And they really look at the review of the available evidence that is out there. And when we review that evidence, we look at different levels and different certainty of evidence, and there is a standardized approach to grade this evidence. Meaning that a clinical trial, as you would expect, has got a much higher value when we look at evidence to decisions than a survey, for example, or a cross-sectional study. So we look at the level of evidence, the certainty of evidence. We assess for bias in some of these trials to really come up with a well-informed decision. I think it's also important to say that part of these decisions and part of this process, we don't only look at effectiveness and harms, we also look at other domains. So we call them values and preferences, equity, cost and cost effectiveness, acceptability and feasibility. And that's really to acknowledge that when we think of guidance from the WHO perspective, we want a globally representative interpretation of the evidence and as much generalizability as possible. So these domains are just as important as efficacy and harms. And I think particularly for DoxyPEP, where we know there's a lot of interest and support from the communities, it really brings an important element into the discussion and into the decision process. Ultimately, when we go through this, we can formulate, or the guideline group, so it's not WHO, it's the guideline group, that formulates either a strong or a conditional recommendation in favor or against an intervention. And that nuance between strong and conditional often falls off, but it is a nuance in the sense that a strong recommendation really is something around probably everybody should be doing this. Whereas a conditional recommendation is a much more adaptive, interactive recommendation where it would be good, the majority of people would want to do it, but there's certainly a level of country adaptation and engagement that is needed to make sure that it's a tailor-made intervention that works in every setting. Next slide, please. So when we look at DoxyPEP, and most of you would have seen this data, there's been 3 trials conducted in monosexual men and transgender women. When you pull these results together, there's a strong reduction in syphilis and in chlamydia incidence, both in incident infections and time to the first infections. So really a strong effect in high-level trials, so high-level evidence of a strong effect. And a modest reduction in gonorrhea in the trials. However, when you look at the global situation on tetracycline resistance in gonorrhea, the preventive effect is probably lower at the global level, given that there's relatively higher rates of tetracycline resistance. So when we think of effectiveness, strong reductions in syphilis and chlamydia, the effect on gonorrhea is probably quite limited, and it depends on your local setting. And it's important to say that real-world data, so early real-world data, support these observations. So programs from various parts of the world, including low and middle-income countries, have reported reductions in syphilis and chlamydia in real-world programs, but most do not see much change in gonorrhea. It's important to say, and it talks to one of my later slides as well, is that there was these real-world programs show reductions in the target group, so in monosexual men and transgender women, But there's some early signals now, 1 or 2 reports that show you might see reductions in the group around these target groups as well, so indirect effects into the general population. And of course, this is important when we think of syphilis, and in particular in women. Next slide, please. So when we think of the risks and when we go through this guideline process, we look at the benefits in different ways. We look at the risks and the impact, in this case, on AMR as well. So when we think of the risk, what's out there, there's data on adverse events, in particular gastrointestinal symptoms, but generally doxycycline PEP is safe. No difference in major adverse events between doxycycline PEP reported in the trials. So what we've done in the guidance that I'll mention later is that to mitigate this risk is to really think of counseling on correct use and monitoring for safety as one of the implementation considerations, but also to avoid repeat dosing within 24 hours. So you don't want to accumulate doses of doxycycline. There's not a lot of data on sexual risk behavior. We saw this in the HIV space in the past, that these kind of prophylactic use would increase risk behavior. When we looked at the trial data, there's not a consistent change in risk behavior or number of sex partners or condomless sex acts. But again, what we do emphasize in the guidance is that this DoxyPEP should be part of a combination prevention package that includes other measures such as condom use. The other question that comes up quite often is, does it affect effectiveness of antiretroviral therapy, opioid therapy, or hormone therapy? We're not aware at the moment of any good data to answer this question, but we don't expect any or drug interaction based on the PK profile. So this is mitigated as well through a regular follow-up. So when we look at the risks, these are very low and mild based on the available evidence. Next slide, please. So the main concern on doxycycline PEP is the impact on antimicrobial resistance. And it's very interesting when you start looking at the evidence and what the evidence shows. So I mentioned at the beginning, we look at different levels of evidence based on how the evidence was collected in these studies. And when we look at the antimicrobial resistance or the impact on antimicrobial resistance, actually the evidence is very thin. And the level or the certainty of evidence is actually very low. But what's out there, we don't see an effect of doxycycline PEP on the effectiveness of the recommended treatments for bacterial STIs. So the normal first-line treatments of our STIs still works. It doesn't seem to impact that treatment. But there are signals of increased tetracycline resistance both in gonorrhea and in some of the commensals, such as Staph aureus or group A streptococcus. Now, for gonorrhea, the question is how relevant this is at a global level. It is a concern in the US at the moment, where we see a reshaping of the gonococcal populations. But in most parts of the world, tetracycline resistance is already very, very high, so the impact is probably small. What remains uncertain is really around the long-term and population-level impacts of doxycycline use on antimicrobial resistance, and any potential indirect effects on, as I mentioned, Staph aureus and the gut microbiome. So in the guideline, there's an approach to really manage this uncertainty through stewardship, so through recommending on-demand use instead of continued use, and really focusing on populations with the highest benefit ratio, integration of surveillance into the recommendation, as you'll see, and implementation monitoring. Next slide, please. So I mentioned the other domains before, and I'm going to go through these quite quickly. But just to say, when we think of values and preferences, both from users and providers, what really came out the evidence review is the community really places a very high value on this intervention, in particular to prevent syphilis. The community also feels concerns around antimicrobial resistance, but the preventive benefit really outweighs these concerns, or is considered to outweigh these concerns. And a user-controlled prevention is really a key feature that is really appreciated in DoxyPEP. It's thought to improve equity if there is regulated use. We probably all know a lot of unofficial or off-label use is already happening in many countries. So from an effective equity perspective, having guidance actually will help improve equity and safe access to these drugs. At a system level, there's high acceptability among users and provider support, and it's a low-cost intervention. So when you look at all these domains, there's a lot of support in favor of doxycycline PEP. Next slide, please. So when we look at all of this evidence out there, so when this is summarized by the Guideline Development Group, there's a high benefit for prevention of bacterial STIs. There's high certainty of data that it actually really reduces chlamydia and syphilis evidence in the incidence in the target population. Preventive effects for gonorrhea is probably limited, and real-world data really support that this is not only something that works in a trial, it's also something that works in real-world settings. And both the community and providers think this is a feasible intervention. So these certain benefits are thought to outweigh the uncertain concerns and the limited risk on adverse events and uncertain impact on antimicrobial resistance. So together, the guideline group came to the conclusion that these benefits outweigh the risks, and we should conditionally recommend doxycycline PEP. Next slide, please. Last slide. So the WHO recommendation on doxycycline PEP is that it may be offered to men who have sex with men and transgender women for the prevention of bacterial STIs. And it's a conditional recommendation with a good level of certainty. And it's important to say that this should be integrated as part of a comprehensive sexual health approach, so it doesn't replace other strategies, it's complementary to other strategies. And for maximum efficacy, to focus or prioritize the groups with recurrent or recent STIs, and in particular syphilis, and those in high incidence sexual networks or settings. And importantly, of course, to have context-appropriate monitoring of antimicrobial resistance along doxycycline PEP policy. Final slide, please. So it's always important also to say what is currently not recommended by WHO. So the evidence review has been around men who have sex with men and transgender women. At the moment, there's no WHO recommendation, so not in favor or against, there is no recommendation yet on doxycycline PEP for cisgender women or cisgender men other than MSM. The one trial in Kenya did not show an effect in cisgender women, but with a low adherence context. So there's several other studies on the way to hopefully answer that question. Doxycycline PrEP is currently not recommended. Again, the trials are underway, and we know there's a continuum from PEP use to PrEP use in some people. So I think we will see things change there in the near future as well. It's a targeted intervention, so not a population-wide intervention in our recommendation. And of course, it needs evidence on resistance monitoring if we are to expand. So it's a quickly changing field. I think there's a lot of parallels with the HIV field, where we also went from PEP to PrEP to broader populations over time. And in that sense, I think it's the same with DoxyPEP. It will reconfigure STI prevention. And I think this is a first step towards much broader use of this application in the future when new evidence becomes available. And with that, I would like to thank you and back to the organizers.
Muchísimas gracias, Dr. Peters, por su presentación. Indudablemente que las consideraciones normativas y las recomendaciones van adaptándose a las realidades y a las necesidades, ¿verdad?, del de la situación de los países. Y bueno, para continuar, nos acompaña el doctor Oliver Bacon, director médico de la San Francisco City Clinic del Departamento de Salud Pública de San Francisco. El doctor Bacon ha liderado la implementación de estrategias innovadoras de prevención de ITS y nos compartirá el día de hoy cómo la experiencia con DoxyPEP ha evolucionado desde la investigación a la práctica en uno de los programas más avanzados del mundo, ¿verdad? Que es el de San Francisco. Doctor Bacon, bienvenido. Gracias por atender nuestra invitación. Por favor, adelante.
You are muted, doctor. We can't hear you.
How about now?
Yes.
Okay.
Yes.
Gracias por la invitación. Yo voy a dar mi presentación en inglés. Okay. All right. Let's see here. Sorry. Okay. ¿Se puede ver mi diapos? ¿Sí?
En este
Aún
momento, no.
¿Todavía no?
En la barra inferior dice compartir, doctor Bacon. En la barra inferior,
Inferior.
de abajo. En la barra de abajo puede ver donde dice
Sí.
compartir.
Sí, un momentito. Ay, 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 ay.
Dr. Bacon, if you want it, I can share for you.
Yeah, that would be better, I think. Sorry.
¿Tú tienes su presentación, Hortensia? Ok.
Okay. Okay, great. Thank you. Sorry about that. I'm going to talk to you about DoxyPEP implementation at San Francisco City Clinic, which is the municipal sexual health clinic run by the San Francisco Department of Public Health. Next slide, please. Okay, so a little context setting. So San Francisco City Clinic sees about 13,000 visits annually by about 6,000 patients. We have a diverse patient population, about 28% Latino, Latina, 15% Black, African American, 13% Asian, 31% white. 40% of our patients are younger than 30 years of age. About 50% of our patients are lesbian, gay, bi, trans, queer persons, 30% men who have sex with women, and 20% women who have sex with men. We offer integrated sexual health services, including screening for sexually transmitted infections, HIV, hepatitis C, as well as diagnosis and treatment for all of those conditions. We have disease control investigators who do partner services and contact tracing and counseling for persons newly diagnosed with HIV and syphilis infections. We provide some women's health. We provide some behavioral health. We have a very large biomedical prevention program that includes HIV PEP, HIV PrEP, and DoxyPEP. We have an on-site clinical laboratory and can do most of our testing on-site. And we offer vaccinations for sexually associated infections, such as hepatitis A, hepatitis B, and Mpox. We have a large training component. We train medical students, medical residents, and fellows, as well as advanced practice nurses. And we do research. We do clinic-based research of our own. We collaborate through NIH and CDC research networks, and we do some industry-sponsored trials. Next slide. And there's a picture of our building on the upper right. Next slide, please. Okay, so we were an early implementer of DoxyPEP. So you're going to hear from my colleague, Dr. Lukemeyer, shortly, who is the principal investigator of the United States DoxyPEP trial. And we were one of the 4 DoxyPEP trial sites, 2 in San Francisco and 2 in Seattle. In May of 2022, the preliminary results of the DoxyPEP trial were released, showing very high efficacy against for syphilis and chlamydia prevention and somewhat lower efficacy for gonorrhea prevention. In October of 2022, the San Francisco Department of Public Health released citywide guidance that we helped to create. And shortly thereafter, in November 2022, we implemented our DoxyPEP program in the clinic. So on the right, you can see our implementation policy. So we offer a 3-tiered recommendation system. So we recommend DoxyPEP for men who have sex with men and trans women with at least 1 male sex partner in the last year and at least 1 bacterial STI in the last year. And these are people who would have met the eligibility criteria for the DoxyPEP trial. We offer DoxyPEP to men who have sex with men and trans persons who had at least 2 male sex partners in the last year, even if they've not had a bacterial STI in the last year. And then we discuss DoxyPEP on a case-by-case basis with women who have sex with men, especially if they've had recent syphilis diagnosis. Next slide, please. So this is a program overview. So our DoxyPEP program is open to patients with any form of insurance or no insurance, unless they're part of a large healthcare organization that provides DoxyPEP on its own. Can you click, please? We have a status neutral approach, which means our DoxyPEP program is open to patients living with HIV or not living with HIV. Click, please. All patients starting DoxyPEP see a clinician at initiation, and that is usually an advanced practice nurse practitioner or sometimes a physician. We have 2 ways of getting patients their DoxyPEP. It is prescribed to pharmacies for patients who have insurance with medication coverage. Click, please. And luckily, doxycycline is so inexpensive that we can purchase it and have it on hand to dispense to uninsured patients in the clinic. Our DoxyPEP program is very clinician light, meaning that while clinicians are involved in initiating DoxyPEP, public health workers who are not clinically trained administer the program and are responsible for tracking patients and providing follow-up communication and prescriptions. So these health workers will determine a patient's insurance coverage, and they will start the prescription process that the clinicians will subsequently sign. They provide education, information, and counseling, and at follow-up visits, they collect information on risk behaviors and adherence. So really, this is an example of task shifting or care differentiation, where clinicians are only involved at DoxyPEP initiation or if there's any complications in follow-up, but the majority of the contact that patients have with the program is with this group of healthcare workers and counselors. Next slide, please. Okay, so what goes on in that counseling appointment when someone is thinking of starting DoxyPEP? So the most important thing is that after getting a thorough sexual history, the clinician and the patient embark on shared decision-making to support the patient's choice to try DoxyPEP or not. And this includes a guided self-assessment of their risk of STIs. We review what we know about the effectiveness and safety of DoxyPEP with patients. We review how to use DoxyPEP, and we acknowledge what we don't know, which is the impact on the microbiome and long-term impact on antibiotic resistance in STIs, but more importantly, non-STI bacteria. And we offer DoxyPEP with a comprehensive package of sexual health services. On the right, you can see our patient-facing information sheet, which we used in the counseling, and we send it home with patients as a reference. Next slide, please. So this is the DoxyPEP workflow, both for initiation and follow-up. On the left-hand side, you can see the initiation workflow. Patients are screened for DoxyPEP at a clinician visit. The clinician takes a sexual history, does the patient education. There's joint decision-making. Orders our baseline tests, which is gonorrhea and chlamydia at all sites of sexual exposure, syphilis screening with an RPR, and HIV screening. If the patient is not already taking HIV PrEP and is HIV negative, we offer HIV PrEP as well. Then we tell the BMP counselor team that they're going to have this patient coming to them very soon. We send the patient to nursing. The nursing team draws labs and then sends the patient to the biomedical prevention counselor, who again reviews the DoxyPEP basics and then pens an order for DoxyPEP. That means they write the order, but they can't sign it because they're not licensed to sign. But that order then appears for a clinician to sign. And here's how we dispense. So it's doxycycline, 200 milligrams daily by mouth, daily as needed after sex. For clinic dispensed doxycycline, that is for uninsured people, we give 100 tablets with 0 refills. If we're sending a prescription to the pharmacy for people who have insurance, whether it's public or private, we order 60 pills with 0 refills. The patient goes, they take their DoxyPEP as needed, and then over on the right, you see the follow-up workflow, which is that when it's time for the patient to refill their DoxyPEP, they call the biomedical prevention telephone line and talk to the counselor. If they have no STI symptoms and they have no contacts to STI, they get signed up for an express visit, which simply means they come in, they get their STI and HIV labs done, they meet with the counselor and get their next prescription for DoxyPEP. If during that phone call, they report symptoms or contact to someone with an STI, then they come in for a full clinician visit. Next slide, please. Okay, we have also inserted DoxyPEP use and adherence questions into our electronic medical record, and our clinicians and our counselors will ask these DoxyPEP questions at every contact with the patient. So there's prompts in the record, as you can see, whom to ask. So city clinic DoxyPEP patients at all visits, and then all patients who are eligible for DoxyPEP, even if they're not our patients, even if they're not in our DoxyPEP program, but are just coming in for sexual health services, and also anyone who's been diagnosed with gonorrhea, chlamydia, or syphilis. Okay, and so the questions are, have you used DoxyPEP in the last 3 months? Yes or no? If you're getting DoxyPEP outside of the Department of Public Health system, where are you getting it from? And that could include other providers or a friend or a sex partner, because we know that people share DoxyPEP with their friends and sex partners, and we think that's fine. And then was your most recent condomless sex covered by DoxyPEP? And then looking at the last 30 days, on how many days in the last 30 did you take DoxyPEP? And the flip side of that question, on how many days in the last 30 did you have condomless sex and not take DoxyPEP within 3 days? And this has allowed us to assemble quite a bit of data on the basics of how people are getting their DoxyPEP and how people are using their DoxyPEP. Next slide, please. Okay, so we did an early analysis of DoxyPEP uptake in our PrEP population. Most of our patients taking DoxyPEP are also HIV uninfected and taking PrEP, and this gave us the opportunity to look at DoxyPEP uptake in a cohort of people with regular follow-up. So this was looking at patients in our PrEP program who from the beginning of November of 2022, when we launched DoxyPEP, until about 6 months later in June of 2023. We looked at 762 people, and you can see the 3 tiers. Each tier has a column. So tier 1 was the patients we recommended DoxyPEP for. And in the orange, you can see those who accepted a DoxyPEP offer. And in the blue, you can see those who did not accept a DoxyPEP offer. And 74% of people, of MSM and trans women on PrEP, who had had at least one male sex partner and at least one bacterial STI in the previous year, 74% of that group accepted the offer of DoxyPEP. Moving to the right, the middle column is tier 2. Those are men who have sex with men and trans persons who've had at least 2 male sex partners in the prior year and no diagnosis of a bacterial STI. Uptake in that group was 60%. And then over on the right is what we named tier 0. Those are largely women and at the time trans men, and about 29% of those people accepted the offer of DoxyPEP. Next slide, please. And remember, this is very early uptake. This is right in the first 6 months of our program. Okay, next slide. So some characteristics in this group. So I just am going to focus on the rows that are highlighted in red. 675 or 82% of the cohort were HIV uninfected and taking PrEP. People chose DoxyPEP or accepted the DoxyPEP offer who had a larger number of sex partners. So you can see 21% of the people prescribed DoxyPEP had 6 to 10 sex partners in the prior 3 months, and 24% had at least 10 sex partners in the prior 3 months. 34% had had any STI diagnosed in the last 3 months, 17.6% with at least 1 episode of chlamydia, 19% with at least 1 episode of gonorrhea, about 6% with at least 1 episode of syphilis, and about 7% who had had multiple STIs in the prior 3 months. This was a group at high risk for bacterial STIs, and they were appropriately choosing to protect themselves with DoxyPEP. Next slide, please. I'm not going to go through this complicated slide in detail, but this is some information on how people took their DoxyPEP based on those use and adherence questions that I showed you in our electronic medical record. And it's broken down by tiers. So in tier 1, the people whom we recommended DoxyPEP for, 70% used DoxyPEP after their most recent sex. They used about 5.7 times in the last 30 days with a range from 0 to 30. And they had about a mean of 3 condomless sex acts in the last month that were not covered by DoxyPEP. In tier 2, those who had multiple partners but no STI, very similar numbers, 71% used DoxyPEP after their most recent sex. They used it about 4 times in the prior 30 days. And again, they had about 3 condomless sex acts in the prior 30 days that were not covered by DoxyPEP. Next slide, please. Okay, so we did another analysis later looking at the effect of DoxyPEP on visit positivity for gonorrhea, chlamydia, and syphilis. And we looked before and after the implementation of DoxyPEP. So before November of 2022 to and after November of 2022. And what we saw basically was a 90% decline in chlamydia visit positivity from before DoxyPEP initiation to after, and a 56% decline in early syphilis, primary, secondary, or early latent syphilis from before the implementation of DoxyPEP to after. Both of those were statistically significant differences. We saw a 23% decline in gonorrhea, but this was not statistically significant. Next slide, please. Okay, so finally wrapping up, what does our DoxyPEP patient population look like at City Clinic? So these are data from 2025. We had 611 DoxyPEP starts in 2025, and you can see the breakdown by age, gender, and race ethnicity. So the bulk of our, we'll call it a DoxyPEP cohort, about 59% were between 25 and 39 years of age, 11% 18 to 24, 16% 40 to 49, and 14% 50 years of age or older. In terms of gender, unsurprisingly, 91% of our cohort consists of cisgender men who have sex with men, 2% consists of cisgender women, and 3% consists of trans women. And in terms of race and ethnicity, by far the largest proportion is made up by Latino, Latina people, 34%, followed by white people who report white race, 31%, Asians, 17%, and Black African Americans, 7%. Next slide, please. So some early insights from the program. We found that patients are often confused about dosing and how it differs from 211 PrEP or daily PrEP. Some people on their own were taking doxycycline every day. Some people were using it in a manner that resembled 211 PrEP, but the vast majority were taking doxycycline PEP as prescribed, which was 2 100 milligram pills within 24 hours after condomless sex, up to 72 hours. We found that most patients did not need a refill at their first quarterly continuation visit. So they were using a little bit less doxycycline than we were prescribing, although there were definitely exceptions to that rule. And there was a very high rate of selective use, as I demonstrated in the adherence and use questions. That means they're not using it with all partners. They're kind of using it with people they have some suspicions about, not their regular partner. They use it with new partners. They use it with partners that they think might be more at risk for STIs. Next slide, please. And a lot of clinical questions have come up since we started doxycycline. How to clinically manage people who report being a contact to someone with gonorrhea, chlamydia, or syphilis if they're taking DoxyPEP. The CDC recommendations are to epi-treat, meaning treat regardless of test results before you have the test results back. We offer patients who are taking DoxyPEP and who are asymptomatic and are not contacts to syphilis, we offer the option to wait until they have their test results back before getting treatment or not, or to do standard of care, which is to treat empirically before test results are back. And we've not measured the proportion of people who elect to wait, but anecdotally, it's pretty high. Another question that comes up is, in the US guidelines, men who have sex with men and trans women are recommended to have STI and HIV screening every 3 months. Do we need to be screening people that frequently if they're taking DoxyPEP? I think that's an open question. And then the other question that comes up is, what about DoxyPrep? And Dr. Peters did mention that there is no current recommendation in favor of DoxyPrep from the WHO. We are somewhat permissive about patients taking DoxyPrep. So we have some people who are sex workers who have sex every day. And based on results from the Tokyo trial of DoxyPEP in female sex workers and some of the data on DoxyPEP that's emerging from Canada, we do discuss the option to take one tablet of 100 milligrams of doxycycline every day for people who have sex very, very frequently, understanding that it is probably pretty effective and may reduce the overall amount of doxycycline that they need to take. Next slide, please.
Doctor,
Yes.
tiempo.
See? And this is just a picture of our city clinic staff at our annual retreat last year. It's an amazing group of people who are committed to sexual health, and it's a pleasure to work with them. And that's the end of my talk. Thank you.
Doctor Bacon, muchísimas gracias por esta excelente presentación contándonos la magnífica experiencia de la City Clinic de San Francisco. De verdad que nos quedamos con ganas de más.
Okay.
Así que creo que valdría la pena seguir conociendo más detalles de esta maravillosa experiencia. Pero bueno, tenemos que continuar. Y tengo en esta ocasión el gusto de contar, de presentarles a la doctora Abigail Fessler, investigadora clínica de la Universidad de Washington. La doctora Fessler ha participado activamente en la implementación y evaluación de programas de DoxyPEP y compartirá las lecciones aprendidas y la experiencia de expansión de esta estrategia en Seattle. Doctora, le agradeceré, por favor, hacer su presentación en los próximos 10 minutos y adelante.
Thank you so much. I'm going to go ahead and share my screen. Are we able to see that okay? Okay. Is everyone able to see that?
Sí.
Okay. Excellent. Thank you so much. Well, I will go ahead and get started in the interest of time. I'll be talking a little bit about our experience with DoxyPEP implementation here in Seattle. And going through some of the data that we have pre and post implementation and some of the lessons learned. So for a little bit of context, we were also one of several sites, as Oliver mentioned, that had participated in the early DoxyPEP trial. Particularly our county sexual health clinic was one of the major sites involved. And so that trial was running from about 2020 to 2022, followed by an open label extension, at which point DoxyPEP was provided to most of the trial participants. And then it wasn't until around March of 2023 that we started really rolling out DoxyPEP within our sexual health clinic to any sort of MSM or transgender woman who was interested in the intervention. Around that time, March of 23, we also published local guidelines on DoxyPEP use. And then it was about a year and several months later, in June of 2024, that the CDC published their national guidelines. So similar to San Francisco, we were one of the earlier cities to start rolling out DoxyPEP among patients in our county clinic. You can see here that after 2023, that's when we started to collect more robust data about DoxyPEP use among patients in the sexual health clinic. And you can see that after a formal rollout of this program, there was really sort of rapid and robust uptake of DoxyPEP, particularly among our MSM population. So this data shows 2023 up through 2025. And you can see here that by 2025, nearly 40% of our MSM seen at the sexual health clinic were using DoxyPEP at least one time monthly. Since the more formal sort of rollout of DoxyPEP, we really have worked to understand, one, is this intervention working, both on the individual level, but also on more of a population and citywide level? And what are some of those off-target or unintended effects of more widespread DoxyPEP use? These have been alluded to by several of the other speakers already. And then who is actually engaging in this intervention? And are we reaching the populations that are most in need of STI prevention resources? So to go through each of these individually, there was very recently, earlier this year, a paper published out of a group here in Seattle looking at the population-wide impact of DoxyPEP implementation on syphilis incidence here in the city. So this group looked both among cisgender men as well as among cisgender women, and also looked at rates of congenital syphilis as well, which we'll talk about in just a moment. Here in this panel on the left, we can see the incidence of syphilis cases prior to implementation of DoxyPEP here in 2023, as mentioned. And we can see that there was about a 53% population-wide reduction in syphilis after the implementation of DoxyPEP compared to what would have been expected based on the pre-DoxyPEP trends, specifically among cisgender men. This is a pretty substantial reduction in population-wide syphilis in and of itself. What was, I think, even more exciting and somewhat surprising was that they also saw a really substantial reduction in syphilis in cisgender women. So about a 47% reduction in syphilis among cisgender women after the implementation of DoxyPEP. And keep in mind that similar to all other sites, cisgender women are by and large not actively participating in this intervention. It's mostly our MSM and transgender women populations who are taking DoxyPEP. And so this was somewhat of a surprising finding, but I think really speaks to the fact that there are really large and impressive population-wide benefits, not just among people who are actively participating in DoxyPEP use, but among the population at large. And this is suspected to be due to sort of overlapping and intersecting sexual networks between cisgender women and cisgender men. The same group also looked at rates of syphilis among pregnant patients and among infants, rates of congenital syphilis over the same time period. Unfortunately, we didn't see the same trend as we had in our general cisgender men and cisgender women populations. Mirroring trends nationally, we continue to see increasing rates of syphilis among pregnant patients and increasing rates of congenital syphilis as well. I think ongoing work is being done to sort of figure out why this may be the case, but it is important to note that at least as of now, a lot of the benefits that we're seeing population-wide for the general population don't seem to be spilling over yet into our congenital syphilis cases. There's also been a lot of work out of Seattle looking at our antimicrobial resistance trends after DoxyPEP implementation. So the data in the next two slides came from a paper looking at doxycycline resistance or tetracycline resistance among individuals at the sexual health clinic, both looking at gonorrhea isolates as well as isolates of Staph aureus, which is a non-STI bacterial, sort of commensal bacteria that can cause infections as well. So this graph shows rates of doxycycline resistance among gonorrheal isolates. You can see here 2023 is when DoxyPEP was really more broadly implemented within the clinic setting. And you can see rates of resistance among gonorrheal isolates prior to DoxyPEP implementation with the mean rate of resistance of about 27%. And then after DoxyPEP implementation, we do see this pretty impressive increase in doxycycline resistance among gonorrheal isolates. By 2025, we were reaching about 70% of our gonorrheal isolates in this clinic were resistant to doxycycline. Some of this data is confounded by increased use of doxycycline for other reasons, over this same time period. And so it's difficult to tease apart the exact driving mechanism of this change. But it does speak to the fact that DoxyPEP is likely contributing to increased gonorrheal resistance to doxycycline. As mentioned, the clinical significance of this, I think, is a little bit unclear. And in many other settings, in many of the settings that you all work in, doxycycline resistance among gonorrhea may already be very, very high to begin with. This same group looked at doxycycline resistance among Staph aureus, so a non-STI bacteria, and did find that among those who had taken DoxyPEP within the last month, doxycycline resistance was about 18% compared to 8% among those not taking DoxyPEP in the last month. That was found to be statistically significant. As a result, in our local guidelines, there was a change to recommend against the use of doxycycline as empiric treatment for skin and soft tissue infections and community-acquired pneumonia, specifically in patients who are taking DoxyPEP, because of concerns that there may be increased resistance among some of the more common bacteria that cause these particular disease entities. And then one of the final sort of ongoing investigative approaches that we're using is to understand equity among those who are taking DoxyPEP and how we are doing in providing this resource to those who are most in need. So here we're looking at just a snapshot of some data that came out of the University of Washington, one of our HIV and PrEP primary care clinics. Each of the numbers here is what's called the DoxyPEP to need ratio, where we're looking at the number of people prescribed DoxyPEP per STI diagnosis. So it gives us a sense of DoxyPEP coverage relative to STI burden, with a higher number representing greater DoxyPEP coverage. And this has been stratified across different racial and ethnic groups among the patients in this clinic. We have each panel representing a different year. While there's a lot to talk about here, what I really want to point out is that here in 2023, we can see sort of all of these DoxyPEP to need ratios clustered around the mean here, indicating that there was relatively similar DoxyPEP coverage relative to STI burden in 2023. And when we compare that to what's happening in 2025, we can see that those who are identified as African American or indigenous populations are having significantly lower DoxyPEP coverage relative to STI burden. And so this sort of spread out, this spreading of these numbers around the mean over time is indicative of increasing disparities in the way that we are prescribing our DoxyPEP by race and ethnicity. So all of these, I think, have led to some key considerations for implementation moving forward. In our context, at least, publication of our local guidelines really did help to drive DoxyPEP use. We saw pretty precipitous increases in DoxyPEP use and acceptance after we published our local guidelines, with national guidelines lagging by about a year and change. We do expect some increase in doxycycline resistance among gonorrhea and among Staph aureus after widespread implementation of DoxyPEP. And this obviously is an area of ongoing research, but should be considered when we think about what empiric antibiotic choices we're reaching for treatment of things like soft tissue infection in folks who are using DoxyPEP regularly. In order for this intervention to be successful, it really does require patient and provider buy-in. And so providing guidance for patients and providers about things, topics like antimicrobial resistance, tolerance, the gut microbiome, has been really critical to getting all of our sort of patients and clinicians on board with rolling out this intervention. It is worth noting that tolerance has been pretty high among our patient population, with GI side effects being sort of the most common thing reported. We have also seen an increase in fixed drug eruptions or rashes presenting after the use of DoxyPEP in some of our patients, and so something to provide guidance to clinicians about. We really have both benefited and continue to struggle with early widespread methods for monitoring DoxyPEP use. I think establishing monitoring practices and research practices early in the initiation of DoxyPEP has been very helpful. So using things like standardized ordering practices so that it's easy to pull DoxyPEP prescriptions from the electronic medical record, implementing, as San Francisco has, and we do something similar in our clinic, patient surveys early in DoxyPEP prescription to understand, who is it that's taking DoxyPEP, how is it being used. If you're able to use, either paper or electronic kiosks for people to fill out surveys at the time that they are presenting, that can be a very helpful way of collecting data. And then really having an equity focus from the start in how we're implementing and rolling out our DoxyPEP to make sure that we are getting this resource to those who need it most will be an important mechanism for maximizing the population level impact of this intervention. So again, I want to thank you so much for having me. This is my contact information, and I look forward to questions.
Muchísimas gracias, doctora Fessler, por esta excelente presentación sobre DoxyPEP en Seattle. Muy interesante esta experiencia que nos comparte. Obviamente, estas últimas consideraciones para la implementación son preocupaciones o, ¿verdad?, del interés de la mayoría de los países. Sin embargo, estos enfoques de implementación que usted nos ha compartido desde la perspectiva de salud pública han sido muy útiles. Así que le damos muchas gracias por esta excelente presentación, doctora. Y para continuar con el programa, la doctora Hortensia Peralta de la Organización Panamericana de la Salud, quien está tras bambalinas en este webinario, apoyándonos. Ella va a hacerse cargo del siguiente panel, donde vamos a abordar, ¿verdad? En este panel, las oportunidades y desafíos para la región en el tema de DoxyPEP. Entonces, doctora Hortensia, adelante con el micrófono para que presente a sus panelistas.
Muchas gracias, Ivonne. Muchas gracias tanto al doctor Peter Renko, al doctor Oliver Bacon, a la doctora Abby Fessler por sus magníficas presentaciones. Vamos a pasar a un panel de discusión y posteriormente del panel de discusión vamos a tener también con nosotros a la doctora Annie Meyer para abordar las preguntas que ya los participantes están haciendo. En el Q&A tenemos ya 6 o 7 preguntas. Por favor, please, Dr. Abby, Dr. Oliver, and Peter. I know Peter is actively answering, but if you can check the Q&A, maybe you can find some some question and you can answer it. Ivonne, también hay preguntas en el chat. Entonces, por favor, te pediría si puedes identificarlas para la siguiente parte.
De
En este
acuerdo.
panel vamos a contar con la participación de la doctora Romina Oliveira. Doctora Romina es médica infectologista con amplia experiencia en HIV y AST, en políticas públicas de saúde. Atualmente atua como consultora técnica do Departamento de Vigilância em Saúde do Ministério da Saúde do Brasil, contribuindo para um desenvolvimento e implementação de estratégias nacionais de prevenção e controle da IST. Sua experiência reúne a perspectiva clínica e programática, o que torna uma referência importante para discutir as oportunidades e os desafios da implementação do DoxyPEP no contexto brasileiro. Tenemos también al doctor Carlos Chávez. El doctor Carlos Chávez es el actual jefe de la sección de infecciones de transmisión sexual, VIH, en el Ministerio de Salud de Panamá y tiene una larga trayectoria que ha liderado importantes iniciativas que han fortalecido la prevención, el diagnóstico y la atención de las personas que viven con VIH y otras infecciones de transmisión sexual. Su participación permitirá conocer la visión de Panamá sobre los desafíos programáticos y las oportunidades para incorporar nuevas estrategias de prevención en el contexto nacional. Y por supuesto, también necesitamos tener la visión desde las comunidades tenemos al doctor Fernando Díaz Pendones. Él es el gerente de COIN, que es una organización de sociedad civil de la República Dominicana, con una larga trayectoria en la promoción de la salud sexual, prevención de VIH, defensa de derechos humanos y trabajo junto a poblaciones en situación de vulnerabilidad. Su participación traerá la perspectiva comunitaria esencial para comprender cómo estrategias innovadoras como la DoxyPEP pueden ser implementadas de forma equitativa, accesible y centrada en las personas. Entonces, la doctora Romina tiene unos pocos slides. No sé si finalmente va a usar su slide o va a hablar sobre las oportunidades y desafíos para Brasil. Vamos a hacerlo en dos tiempos. Quizás podemos hablar de las oportunidades y luego hablamos cada uno de las oportunidades y luego hablamos de los desafíos. Adelante, Romina.
Yes, thank you, Hortensia. I'm not sure if I could speak in Portuguese, but let's go in English.
Você pode falar português. Temos tradução
Ah,
português, inglês e espanhol.
sim, francês, obrigada, então. Então, vamos continuar. Let's change to Portuguese, please. Pelo nosso Ministério da Saúde no Brasil,
No
consideramos e agradecemos a
escuchamos,
oportunidade.
Romina. Sí.
Não, talvez a tradução, maybe the translation team. Do you listen, please?
Muy bien, doctora, hoy sí.
Yeah, can I continue? Podemos continuar?
Você pode continuar. Você escuta muito bem. Muito bem.
Ok, obrigada. Então, pelo nosso Ministério da Saúde no Brasil, consideramos e agradecemos o convite, considerando uma oportunidade ímpar nesse momento para discutir com os demais países e também para ouvir, né, da fonte dos nossos pesquisadores, cujos dados temos estudado com tanto interesse nos últimos anos, nesse momento, nesse webinário. Também, da mesma maneira, reconhecendo o trabalho do grupo técnico da OPAS e da OMS sobre essa temática da DoxyPEP. Pedimos desculpa pela ausência de Pamela Gaspar, nossa coordenadora nacional de vigilância das IST no Brasil, está no momento em outro evento, e eu, que sou parte técnica desse time, que estivemos trabalhando aí na aprovação e também na implementação da estratégia no país. Pensando em oportunidades, antes de mais nada, é importante sempre reforçar, o Brasil vive uma série histórica de bastante preocupação e efeitos na nossa série histórica epidemiológica praticamente dramáticos, com uma epidemia de sífilis adquirida. Nossa região também sofre os impactos desses dados e dessa questão da sífilis adquirida nos outros segmentos populacionais. Então, para que tenham uma ideia, em 2024, mais de 250 mil casos de sífilis adquirida, impactando em 90 mil casos em pessoas gestantes e ainda uma situação dramática de 20 mil casos, somente em 2024, com sífilis congênita. Dentre as nossas oportunidades, com a estratégia DoxyPEP, a ideia da aprovação para o nosso Sistema Único de Saúde, para o SUS, está focada em minimizar o cenário de sífilis. Reconhecemos que no nosso país temos evidências de um quadro de resistência antimicrobiana às tetraciclinas em relação à gonorreia, ao gonococo. Portanto, o nosso foco com a aprovação e incorporação da estratégia no SUS está focado em sífilis e clamídia. Como processos de oportunidade, temos, então, um olhar para a nossa rede de serviços de prevenção combinada, assim denominamos no nosso país, com aproximadamente, pelo SUS, nosso Sistema Único de Saúde, aproximadamente a oferta de 6 mil novas ofertas de PrEP para HIV por ano, além de cerca de 56 mil dispensações pontuais de PEP para HIV e demais ISTs também por ano. A rede de serviços ela é conformada nas 5 regiões brasileiras, com a oferta de exames de monitoramento laboratorial, que incluem as testagens para as outras IST, bem como para o HIV, e também incluem, dentro desses programas de PrEP para HIV, também a biologia molecular, o screening para a clamídia, E para gonococo, também por biologia molecular, está incluído dentro dessa rede que já está composta por esses serviços no nosso país. Uma outra oportunidade que vislumbramos e verificamos é que a doxiciclina já vinha incorporada ao SUS, com suas indicações clínicas para as IST também, alternativamente para sífilis, como vocês conhecem, e também para a clamídia e para outras indicações clínicas. Então, o nosso pleito para avaliação da Comissão Nacional de Tecnologias no SUS, para avaliação de novas tecnologias no SUS, ele foi um pleito para ampliação de uso da doxiciclina, pensando na modalidade de PEP, que ainda não era incorporada e não tinha a situação no nosso país. Uma outra oportunidade vista foi que os estudos de custo-efetividade relacionados ao insumo antimicrobiano em si, ao próprio antibiótico, se mostraram bastante promissores, e principalmente pela nossa rede de serviços em PrEP e em PEP, em PrEP para HIV e em PEP, já disponibilizaram os exames. No Brasil, todas as pessoas com exposições desprotegidas ou que desejem se testar a qualquer momento têm acesso a esses exames. E dentro dos programas de PrEP, dos usuários de PrEP para HIV e de PEP, existe uma periodicidade, incluindo os testes de biologia molecular. Então, ademais, sendo um país com mais de 10 anos da estratégia de PrEP para HIV implementada, sabemos dos desafios, sabemos dos percalços já dessa estrada pavimentada para a PrEP para o HIV no país. Também pretendemos que esses avanços e esses conhecimentos do que já poderíamos ter melhorado na PrEP para o HIV também possam ser uma estrada promissora para a DoxyPEP no nosso país. Talvez essas sejam oportunidades que possamos comentar nesse momento, e nossos desafios também estaremos à disposição para comentarmos. Obrigada, Hortência.
Obrigada, doutora Romina, pela sua resposta. Continuamos con el doctor Carlos Chávez. ¿Cuáles son las oportunidades que en esta implementación, doctor, para Panamá?
Bueno, muchas gracias, Hortensia, por este espacio. Bueno, la verdad nosotros estamos muy contentos en Panamá porque hemos avanzado significativamente hacia la implementación de la DoxyPEP. Ya tenemos una guía desarrollada en el apoyo técnico de la Organización Panamericana de la Salud. Ya estamos en los procesos de validación interna del país y también estamos ya próximos al proceso de la parte administrativa legal que implica poder adoptar entonces una iniciativa, una estrategia dentro del país. O sea que en los próximos meses probablemente ya Panamá tendrá una guía publicada en diferentes ámbitos legales para poder ser implementada en Panamá la DoxyPEP. Nosotros vemos que algunas oportunidades que como que concuerdo con Brasil, creo que la más importante es la experiencia que hemos tenido como en los programas de VIH, sobre todo en la PrEP. Ya tenemos una primera experiencia en la parte de prevención, dando bebidas biomédicas específicamente para poder entonces implementar el programa de DoxyPEP, y tenemos una plataforma ya establecida de pacientes que utilizan la PrEP y que son también candidatos para la DoxyPEP. Entonces ahí tenemos ya una plataforma establecida donde tenemos los flujos de atención, tenemos todo el seguimiento que se le da al paciente, y bueno, es más fácil ya con una plataforma preestablecida o una estrategia ya establecida poder que nosotros podamos introducir otro mecanismo más o una estrategia adicional para prevenir otra infección de transmisión sexual. Entonces, obviamente tendremos que hacer ajustes en los modelos de atención ya establecidos, pero creemos que, igual que Brasil, esa es la principal oportunidad que tenemos ya como experiencia en los programas de VIH. Yo creo que también otra oportunidad muy importante es que al tener una nueva estrategia, siempre queda la duda de cómo logramos que la demanda por parte de la población. Y bueno, nosotros ya en Panamá hemos tenido experiencia en toda esta parte de crear la guía como tal y que nos hemos reunido con los diferentes médicos infectólogos, médicos que hacen prevención en nuestras clínicas amigables, hemos podido identificar que ya hay una demanda creada por parte de la población. O sea, ya la población va a nuestros servicios de prevención que y que ellos ya son usuarios de PrEP y ya están solicitando el uso de DoxyPEP. Entonces nuestros médicos ya se han ido entrenando, han ido ya realizando la atención como tal y han podido entonces ver han podido tener la experiencia de cómo es el uso de la DoxyPEP en sus escenarios clínicos. Y bueno, esto crea la mayor facilidad de que ya teniendo a médicos que ya saben cómo hacer el uso de la DoxyPEP y además que ya hay pacientes que la están solicitando, es más fácil que la estrategia crezca rápidamente para poder lograr el objetivo final que queremos, es ver la reducción de los casos de sífilis. Bueno, eso sería básicamente la parte de la informalidad. También es importante que otra oportunidad que vemos es que ya la región, sobre todo en Estados Unidos, y creo que es una de las oportunidades más importantes, es esta que tenemos el día de hoy, porque como Panamá y creo que Brasil ya hemos tenido también nosotros una conversación entre ambos países sobre la DoxyPEP. Y hemos identificado que hay una duda muy importante que es a la parte de implementación, cada cuánto vamos a poder nosotros dispensar como tal la doxiciclina, que creo que es lo que hay todavía ambos países podría verse como una interrogante que todavía tenemos, pero otra oportunidad que he podido identificar es que al tener estos espacios, hemos podido, entonces yo por lo general, el día de hoy he podido dar a través de la experiencia que he presentado a la Clínica de San Francisco, he podido identificar cómo podría ser en Panamá la dispensación de la doxiciclina, que es la principal interrogante que hemos tenido por parte de los médicos, cada cuánto vamos a dar una receta de doxiciclina, cada cuánto vamos a poder el paciente reabastecerse como tal de la doxiciclina. Entonces yo creo que estas serían, por decirlo así, a rápidos rasgos para aprovechar el tiempo, serían que los programas que ya tenemos actualmente de prevención combinada son la plataforma indicada para poder montar esta nueva estrategia, que ya se ha creado una demanda informal por parte de la población y los médicos dentro de nuestro registro de prevención y que, bueno, hemos tenido también oportunidades de poder compartir a nivel regional cómo están aplicándose esta estrategia en otros países para poder entonces nosotros adaptar nuestras estrategias e implementaciones en cada una de las regiones.
Muchas gracias, doctor Chávez. Vamos a pasar con Fernando Díaz Pendones del COIN. Adelante.
Hola, muy buenos días a todos. ¿Me escuchan bien, verdad? Ok. Bueno, de nuestra parte, agradecemos la oportunidad creada por el Grupo de Cooperación y la OPS para compartir con ustedes en esta mañana sobre una de las estrategias que una vez se adoptan dentro del contexto de la prevención combinada, pues constituye una ventana de oportunidad para que los países podamos irle dando frente a la necesidad de este resurgimiento del aumento del número de nuevas infecciones de sífilis, así como también el incremento de las personas que se ven afectadas por la sífilis congénita. En la República Dominicana, la experiencia que hemos tenido con programas como el de VIH, tuberculosis, malaria, que son programas que nacen con un apoyo muy importante de la cooperación internacional, hizo que el país hiciera sus primeros pininos o sus primeras experiencias para incorporar de forma sistemática intervenciones de forma concreta y son los programas que mayor éxito han tenido desde el punto de vista de la salud pública. Ahora bien, el país, aunque todavía no tiene los protocolos definidos todavía para la implementación de DoxyPEP, eh, no está en las organizaciones y en los centros, gracias a la incorporación por parte de los proveedores, hemos hecho los primeros ajustes donde los mismos usuarios como comentaba el doctor anteriormente, son los que van poniendo el tema de conversación. Y como recomendaciones o como incorporaciones que deberíamos ir tomando en cuenta dentro de del contexto de la República Dominicana, fueron tocados por los demás expositores. Básicamente, la estrategia se tiene, número uno, que incorporar a la prevención combinada que ya está disponible en muchos de los centros como el nuestro. Se necesita de un piloto evaluativo inicial en el cual se pueda sistematizar las recomendaciones en base a la experiencia nacional. Los sistemas de información en la actualidad, aunque tenemos, por ejemplo, el sistema para el monitoreo nacional de la dispensación de PrEP por parte del Servicio Nacional de Salud y el Ministerio de Salud Pública, así como también nosotros a nivel local tenemos un sistema propio. La recomendación es incorporar la oferta, la aceptación y el uso de la DoxyPEP, que todavía ni siquiera nosotros la hemos incorporado del todo, aunque la tenemos disponible para los usuarios y se las ofertamos. Falta sistematizar el uso de forma segura. Es importantísimo asegurar el acompañamiento clínico, como observó uno de mis colegas anteriores en la exposición, donde se hacía mucho énfasis en la parte del acompañamiento y en la consejería que se debe dar a la hora de implementar, porque esta intervención viene con muchas posibles dudas que se van a dar de parte de los usuarios sobre cómo utilizarlo, si lo tienen que utilizar de forma continua, cuáles son los riesgos. Y esta integración tiene que realizarse de la mano del monitoreo eh, de la resistencia microbiana, que es una de las preocupaciones que se externaron durante toda la presentación, ya sea que se generen en el contexto de estafilococos aureus que sean resistentes a tetraciclinas o de del mismo monococo. Eh, pero son cosas que se tienen que tomar en cuenta porque en la actualidad el beneficio que se está dando en los países que sí llevan una sistematización vale la pena el riesgo. Y lo más importante es que se deben priorizar las poblaciones porque, como se comentó, todavía no hay una recomendación general del uso de la doxyPEP. Por ahora se recomienda en el contexto de las poblaciones de hombres que tienen sexo con hombres y las mujeres trans, debido al contenido eh, de la carga por sífilis desde el punto de vista epidemiológico. Ahora bien, esta estrategia se tiene que emular los modelos donde tenemos una serie de indicadores que nos permiten monitorear el éxito o las oportunidades de mejora. Por ejemplo, podemos incorporar tableros en los que, así como el Servicio Nacional tiene tableros para el monitoreo del VIH, igual que el CONAVICID aquí en República Dominicana, podemos tener tableros que permitan medir el número de personas elegibles, el número de personas que inician la doxyPEP, con qué frecuencia se utilizan, así como la documentación de eventos adversos que puedan surgir del, de la implementación. Para finalizar, solamente me gustaría puntualizar que estas intervenciones, y en especial en las poblaciones a las que están dirigidas, son intervenciones que ya están de la mano de las poblaciones. Son los mismos pacientes que te ponen el tema de conversación. Recuerdo en los primeros, como en el 2024, fueron las primeras veces que recuerdo que mis médicos que trabajan en el área de PrEP me preguntaban, mira, me están preguntando mucho sobre esta intervención, yo la estuve leyendo, pero todavía el país no tiene nada estandarizado. Y eso obliga a que nosotros, de cara a ser los responsables tanto de la planificación como de la implementación de intervenciones, tengamos en cuenta el gran nivel de empoderamiento que tienen las comunidades y por lo menos en la República Dominicana, la PrEP es liderada precisamente por los hombres que tienen sexo con hombres. Entonces, incorporar en la PEP es una demanda todavía no satisfecha y una tarea pendiente por parte del sistema aquí en la República Dominicana. De mi parte es todo.
Muchas gracias, muchas gracias, Fernando. Yo quiero también para que nos escuche la audiencia, el público y también nuestros panelistas que muy amablemente han compartido esta experiencia con nosotros. La región de América Latina y el Caribe se está preparando para empezar con la implementación de la estrategia de doxiciclina PEP, ¿no? De DoxyPEP. Como han escuchado, Brasil ya ha avanzado, Panamá ha avanzado, República Dominicana ha avanzado, pero también hay otros países que están preparando sus guías. Por ejemplo, Cuba también está listo para avanzar. Entonces, quizás invitar a los compañeros de otros programas que están en la audiencia a que coloquen sus preguntas, sus dudas, así como han estado colocando en el Q&A. No las coloquen en el chat porque nos hace un poco más complicado, porque la doctora Annie, que va a hacer el key remark y nos va a ayudar con la discusión final, está muy activamente tratando de contestar todas estas dudas sobre dosificación, limitaciones en la implementación. Por ejemplo, Romina, yo pienso que considerando a dimensão territorial do Brasil, a diversidade dos contextos epidemiológicos, as diferenças na capacidade de resposta entre estados e municípios, quais são, em sua opinião, os principais desafios? O que estratégias o Ministério da Saúde considera fundamentais para garantir uma implementação segura para todas as pessoas? Ou vai ser uma focalização? Como vai ser a enfrentar esses desafios?
Sim, obrigada, Hortência. Então, temos um descompasso que já existe, como alguns colegas já comentaram aqui também, sobre a questão de vida real, prescritores indicando e usuários comprando, adquirindo com seus recursos próprios. Fomos a uma consulta pública que foi bastante emblemática para o SUS, após um longo período de análise de tecnologias em saúde, que é um trâmite oficial dentro da que segue um trâmite oficial dentro da nossa Comissão Nacional de Tecnologias, de Avaliação de Tecnologias no SUS. Esse descompasso da nossa aprovação para incorporação no SUS se dando em 2026, com uso ao longo, principalmente dos últimos 3, 4 anos, possivelmente, de uso real e vida real. Esse talvez seja o primeiro desafio para que o nosso protocolo, que também está em desenvolvimento, Carlos mencionou também, no Brasil estamos trabalhando com os experts dos nossos comitês assessores para o desenvolvimento do protocolo. Um dos desafios vai ser como incluí-la. Com que posologia esses usuários chegarão? Com quanto tempo de uso de Doxy, sem algum monitoramento orientado, esses usuários chegarão também para nós dentro das nossas ofertas dentro do SUS. Claro que a vastidão, e a extensão territorial e populacional e as questões heterogêneas nas redes de serviço, elas representam desafios. Com isso, temos trabalhado para ampliação dos pontos de coleta para a biologia molecular. Muito possivelmente, nosso maior desafio seja que essa implementação de forma faseada, ela já traga desde o seu início o monitoramento da ideação da possibilidade de resistência antimicrobiana dentro do nosso país. É preciso desenhar um baseline do uso, da utilização da doxiciclina antes e para que possamos ter o acompanhamento após a introdução enquanto DoxyPEP nessa indicação no nosso país. Para isso, temos trabalhado com a coordenação de laboratórios gerais do SUS, LAFEM também, e também trabalhado junto à nossa Agência Nacional de Vigilância, que é a Anvisa, bastante conhecida no nosso país, por conta da rede de hospitais Sentinela no SUS. Então, a preocupação com o desenvolvimento para questões individuais do microbioma do usuário e da usuária de DoxyPEP, bem como possibilidades de pressão seletiva comunitária, como todos conhecem, principalmente com foco em gram-positivos, e o foco nas IST, nas bactérias IST, micro-organismos IST, e os não-alvo também das IST. O desenvolvimento dessa rede é um desenvolvimento que vai estar desde o início dessa implementação e por fases. Em relação às culturas de vigilância, nesse sentido do monitoramento da possibilidade de resistência antimicrobiana em relação à estratégia DoxyPEP, temos também desenhado uma possibilidade de acompanhamento amostral, considerando a questão populacional no país e já uma forte intenção de uso dentro das populações-chave e para aqueles que já estão usando, sabemos que possivelmente esse monitoramento não consiga ser per capita. Não consigamos para cada indivíduo, mas de uma maneira amostral, representativa, ligada aos laboratórios com maior estrutura para isso no nosso país, para que possamos monitorar ano a ano, né, a possibilidade, então, das pessoas em uso da DoxyPEP com o desenvolvimento ou o possível desenvolvimento, potencial desenvolvimento de resistência antimicrobiana. Um outro desafio, acho que Fernando tocou bem nessa questão, é que, ao mesmo tempo que temos todo o trabalho prévio com a PrEP no país, que ano passado completou 10 anos de PrEP para HIV, a estratégia dentro do nosso país, também há as inequidades em saúde. Então, a questão dos determinantes sociais em saúde sempre são um desafio, com barreiras de acesso, questões relacionadas, apesar do Brasil ter todo esse trabalho junto às comunidades e um trabalho forte em quebra de estigmas e preconceitos, sabemos que há barreiras relacionadas. E um dado que nos chama a atenção, ainda dentro da nossa população de usuários de PrEP para HIV, é que atualmente, com 156 mil usuários, apenas um cenário para que conheçam, temos somente 2,6, 2,7 de usuários dentre população trans, mulheres trans ou outras, né, associadas a outros segmentos de não binariedade que estão acessando a PrEP para HIV hoje no nosso país. Então, as barreiras com recorte de raça e cor, as barreiras com situações de estigma em um país que ainda enfrenta uma homofobia e uma transfobia bastante poderosas, digamos, ainda na nossa região, também pensando na população, que é a população-alvo para a DoxyPEP, também se impõe como barreira, como possibilidades de desafios que deveremos trabalhar a partir dessa implementação. E finalizando de uma maneira otimista, também gostaríamos de trazer aqui para a discussão que estamos com 2 estudos, ensaios clínicos prospectivos implementados e com recrutamento aberto no nosso país, que estão acontecendo, a nossa implementação no SUS está acontecendo em paralelo já a esses estudos, que, por que não serão, né, com certeza, estudos que serão dados de usuários brasileiros que irão nortear as próximas etapas da implementação. Temos o DoxyReal, né, o DoxyReal, que é um estudo pela Fiocruz do Rio de Janeiro, o grupo da doutora Beatriz Grinstein, que tem bastante experiência com a população trans e com estudos com pares na população trans e outras populações com vulnerabilidades acrescidas, junto da nossa colega Maiara Seco. E na Universidade de São Paulo, temos o Doxy São Paulo, também coordenado pelo Ricardo Vasconcelos, nosso colega também emblemático aí na luta pelos direitos humanos e direitos das pessoas vivendo com HIV
Obrigada.
e no trabalho com PrEP. Muito obrigada.
Obrigada, Romina. Tenemos una situación, es que la doctora Annie Luetkemeyer, que nos va a ayudar con el key remark y las discusiones, se tiene que ir en 10 minutos. Entonces quiero pedirle a Carlos y a Fernando si le podemos permitir que haga como algún resumen, que yo creo que ella ha estado muy activa en el Q&A. Gracias. Thank you, Dr. Annie, for answer give answer for the question in the Q&A. And I know you have a summary key remark maybe for especially I would like to ask you about the cisgender women, because I see a lot of questions of cisgender women. And probably if you notice some recurrent point, or if you want to clarify some of the very important keys from this implementation matter.
Yeah, thank you so much. And first of all, thanks for including me and for this really wonderful panel. It's terrific to see so much interest and so much commitment to improving sexual health and meeting people where they are. I think I have 3 take-home points that I have from both this experience and then I think our collective experience doing DoxyPEP research and implementation. One is the point that was made by one of the earlier speakers. Patients are already taking DoxyPEP. So not everyone, and it's not reaching all the right people, but there's a lot of discomfort sometimes from providers. Boy, is this the right thing to do? What are the consequences? I think we need to be very thoughtful about that, but talk to your patients. Many of them are already taking it. So that's why it's really critical to have guidelines and to have meetings like this so that you can provide clinician guidance to say, hey, you shouldn't be taking more than this number of doses. This is who should take it. This is who shouldn't, because it's already out there, and this is a widely available medication. And public health is really important to allow this to be done in a safe and responsible way. And if we kind of put our heads in the sand and say this isn't happening, then we're losing an opportunity. The second point that I would make is I've heard people say many times, antimicrobial resistance monitoring is so important. It is very important. It is also extremely difficult. The one we really think about is gonorrhea, and we could argue that you don't use tetracyclines to treat gonorrhea, and we know that resistance is really going up. But I would say most countries do a very poor job of gonorrhea antimicrobial resistance surveillance. In the United States, this is not standard. We have a very small program. It's hard to get gonorrhea culture. So I think we need to really think about what we mean when we say resistance testing or monitoring for that. Are you talking about gonorrhea? It's important to have programs to have an idea of what's going on with that, but often those are very, very small and can be challenging. We don't do chlamydia drug resistance, and we've not seen any drug resistance that's clinically significant for chlamydia with doxycycline, so that's good news. And then people often ask, is it going to stop working for syphilis? Will we get resistance? Well, we can't do monitoring for that. It's very hard to do syphilis culture, so that's a challenging. We haven't seen any signal that doxy no longer works for syphilis. It's worked for a very long time, and we haven't seen penicillin resistance. But what that monitoring looks like, we need to be really thoughtful about. I think Dr. Fessler and Dr. Bacon provided some nice examples of what the literature has done to look at things like Staph aureus, and I think the microbiome is tricky. So I would say it is important to look at your STI trends, understand what's working, see where it's not working, but be really thoughtful about AMR monitoring and what we mean by that, because sometimes that's a term that's used, and I'm not sure that we know what it means. I think that the last comment that I would make is that, and I think this has been touched upon by many folks along the way, DoxyPEP is not the answer for everything, and it's not even the answer for most things. So it has to be part of a larger sexual health package, which I think we all know, but it is sometimes people, and they're well-meaning or patients get excited and they think that DoxyPEP will do something that it doesn't. It's really good for syphilis and for chlamydia. We've probably lost its efficacy for gonorrhea, and it already started out behind that. And what it won't do is prevent or reduce the risk of diseases that we have really good interventions for. We have vaccines for Mpox, for HPV, for HBV. Those are all sexually transmitted diseases. And we have PrEP and HIV treatment to reduce the risk of HIV and to treat people with HIV. And so we've got to put this in the context of a sexual health package, which again, I know I'm preaching to the choir. Everyone here is committed to that, but we have to remind our patients who are really, there's a lot of enthusiasm, oh, I want to take DoxyPEP. That's an opportunity to revisit, are you on PrEP? For HIV, those things should often go together because of the same risk factors. So I really want to congratulate the group for, I've heard this be brought up many times. We do hear in the reports of people taking DoxyPEP without PrEP. And so we want to figure out better ways to try to make sure that this is part of a bigger package. Then the counseling and the messaging, because this is a public health approach, we don't want people using DoxyPEP to treat their own sexually transmitted infection because they think they might have gonorrhea or syphilis. We would rather have them get diagnosed. We don't want them taking doxycycline to treat a skin infection or pneumonia or giving it to a sick friend or a child. It's very tempting to do that, and every country is different with what the access to antibiotics is. They may be able to get these antibiotics anyway, but I think one of the challenges in a public health approach, like Dr. Bacon described, where everybody's not seeing a doctor, that's not feasible, is to make sure that really clear messaging is out there about how to do this safely and what DoxyPEP should not be used for. So you're not to self-treat sexually transmitted infections, don't share with other people. And there's a lot of, I think, really exciting data that you can get from your systems. That's the last point that I'll make that I think has been nicely highlighted. We need to know how this works and to monitor it along the way. So when you're thinking about rolling out these plans, and many of you are already on the way, think about what you can do to look to see, how is this working? Are we seeing a decline in our syphilis rates? Who are we missing? Who are the people who are continuing to get syphilis, and why are we not reaching them with DoxyPEP and with other interventions? Because if you set yourself up in the beginning to have some basic surveillance, you can really have some beautiful data that's been informative, and sometimes it's surprising, like the data from Seattle. In San Francisco, we didn't see a decline in women who by and large at that point in time weren't taking DoxyPEP. So will we start to see a spillover? I certainly hope so, but we didn't see it in Seattle in pregnant women. So I want to just stop there. I think those were my main take homes, in addition to being just very thankful that this community is engaged in this work to help take care of people and promote their sexual health and well-being. Maybe the one last closing thing to say, and this got brought up a few times, which is that stigma is such an important issue to address, and I think stands in the way of people receiving sexual health and HIV health services. So the more that we can meet people where they are and acknowledge who they are and what their identity is, and not stigmatize that goes a very long way, because people can't get the care they need if they feel that they're being judged and that the door is not open to share what they're doing. And I've heard such open and welcoming approaches on this call today, and I think that that's really where we have to start, so that we're not shaming people about what they're doing and saying things like, you just need to use condoms, and if you don't, then I'm not going to give you medications. So thank you for meeting them where they are and for your wonderful work.
Thank you very much, Dr. Annie, for your presence, for your words, and for your help in the implementation. I'm sure that we will continue asking you, Dr. Oliver, and also Dr. Presley, for your help for the different programs in our different implementations. Para continuar y para ir cerrando, porque ya pues el tiempo nos ganó, esta conversación es muy emocionante, muy motivante. Gracias por responder todas las preguntas. Voy a dar la palabra primero a Fernando para que el doctor Carlos, que tiene además el sombrero del secretario de GCTH, cierre. Fernando, de todo lo que has escuchado y de los desafíos que hay en Dominicana, ¿cuál sería tu principal mensaje para las comunidades, para los trabajadores, para los gobiernos en relación a esta estrategia? ¿Cómo cerrarías tú?
Bueno, yo me enfocaría en la línea de que esta implementación o esta estrategia dentro del contexto de la prevención combinada ya está siendo utilizada por por las poblaciones. Y la idea que debemos llevarnos o el mensaje que debemos llevarles a nuestros tomadores de decisiones es que la intervención es efectiva. Es efectiva para el contexto de la sífilis y la gonorrea, incluso con cierta evidencia para clamidia, que son infecciones que normalmente no se le da la importancia que debería y precisamente en ese contexto, pues debemos reforzar la implementación en la prevención de estas entidades. Por ejemplo, ya el país o los países pueden estar haciendo la implementación del testeo dual en comunidades de VIH y sífilis, y perfectamente se pudiera estar ofertando la DoxyPEP junto con los demás paquetes de prevención dentro del paquete de prevención que se le ofrecen a los usuarios. Pero lo más importante es que esas intervenciones que hacemos en la comunidad pasen a ser monitoreadas de forma sistemática por los programas nacionales. Que si yo entrego una prueba o realizo una prueba de sífilis en un entorno comunitario y al mismo tiempo, al estar negativo, coloco a disposición del usuario la DoxyPEP, que pueda reportarse esa intervención y lo más importante, medir el impacto, porque en la actualidad hacemos muchas cosas de las cuales no tomamos las informaciones necesarias para poder medir su impacto y son de las grandes deficiencias que tenemos en América Latina, la falta de generación de información y médicamente relevante. Entonces, me quedaría con esa intervención de que los usuarios ya la están usando, está en nosotros estandarizar el uso y darles las informaciones correspondientes para que la estrategia sea implementada de forma correcta.
Muchas gracias, Fernando. Muy buen mensaje. Doctor Carlos, bueno, le toca cerrar. Antes de darle el cierre, quiero agradecer a la doctora Romina, a la doctora Abby, al doctor Oliver y a la doctora Annie por su participación, por su ayuda y vamos a continuar en contacto. Seguramente vamos a hacer un webinar de DoxyPEP segunda parte con otros países o cuando vayamos un poco más avanzados en la implementación. Gracias, doctora. Sé que se tiene que ir. Adelante, doctor Carlos, su cierre.
Gracias. Cumpliendo el tiempo, bueno, yo sí, no quisiera cerrar sin antes decir primero que debemos tener claro que no demos, creo que uno de los desafíos más importantes es que la población entienda y que todos los profesionales entendamos que la doxipep no vino a desplazar ninguna otra una intervención fundamental que tenemos para las ITS VIH. O sea que el uso consistente y correcto del condón sigue siendo nuestra medida más efectiva. También importante tener en cuenta que vamos a tener muchas dudas en la implementación. Creo que eso se ha podido evidenciar por los diferentes países que hemos comentado y por los diferentes preguntas que he visto durante todo el webinario. Y que, bueno, en la medida de lo posible, no dejemos que las dudas en la implementación no sea una barrera estructural para poder implementar como tal la DoxyPEP en la región. Que también invito a todos los países que se encuentran el día de hoy a abordar estas nuevas recomendaciones, adoptar, perdón, estas nuevas recomendaciones que nos ha hecho la Organización Panamericana de la Salud y la Organización Mundial de la Salud sobre el uso de OCPEP. Ya ustedes han podido escuchar, algunos países estamos avanzando hacia la adopción de estas recomendaciones, así que insto a todos los colegas de la región que puedan adoptarlo dentro de sus programas de prevención. Y también otro punto importante que dentro de la OCPEP no podemos dejar atrás a las personas que ya viven con VIH, porque también es una población que puede ser beneficiada y que va a tener un gran impacto en el uso de la doxyPEP, porque bueno, al ser un programa en el cual queremos evitar ITS, nos vamos a enfocar mucho en la parte de prevención, pero también puede ser, este programa puede ser incorporado dentro de nuestros servicios de atención dentro de las clínicas de terapia antirretroviral. Y bueno, lo último que me gustaría rescatar desde la intervención de la doctora Ani es que, y creo que esto puede ser muy bien traducido, es que debemos abrazar la realidad de toda la población de nuestra región y es que estos tipos de estrategias van a ser la respuesta para poder abordar toda la realidad que tenemos en el contexto de la región de Latinoamérica. Así que gracias a todos por su participación. Espero que podamos seguir compartiendo y que el webinar del día de hoy haya podido responder las dudas o por lo menos dar luces hacia la implementación de la DoxyPEP en cada uno de nuestros países. Saludos.
Muchas gracias y que estén bien todos. Thank you very much. Obrigada, doctora Romina. Thank you, doctora Abby.
Obrigada.
Gracias a todos los participantes. Nos vamos a ver en el segundo webinario, creo, de DoxyPEP muy pronto. Nos
Gracias.
vemos.